very good morning good afternoon to one and all, and let me start by thanking Madhu sir for inviting me here. Now this is something which is increasingly becoming a question that is being asked, whether we really need to do the axillary dissection at all. You know, when can we spare the axillary dissection is something, the de-escalation therapy which has been happening in breast, not only in the primary site but also in the axilla, has got many takers now, and is really something which is definitely doable. So what do we mean when we say sparing the axillary dissection? There are two ways of looking at it. One is that you do only sentinel node biopsy and don't do any further axillary dissection, or you don't do any axillary surgery at all. So both these are possible. So we just have a look at how, what are the available evidence for this. Now, right from the 1990s, when the sentinel lymph node biopsy was introduced, you know, we came to the long-term results of the NSABP and the Milan study, which showed us that axillary node removal is not really changing the overall survival. It does not really change the survival. Survival is not related to the axillary node. The axillary node is a prognostic factor, yes, but it doesn't affect the survival. The removal of the axillary node doesn't change the survival in any way. So people started looking at whether, when the sentinel lymph node biopsy is positive, whether you could avoid further treatment with the axilla. And there are a whole set of trials here which looked at doing nothing or giving radiotherapy to the axilla as an alternative to axillary lymph node dissection. This was all done for the clinically node negative patients, and for the clinically node positive patients, people again started introducing, in the 2010 onwards, introducing sentinel node in the N1 group after neoadjuvant chemotherapy, and for those who became N0 after chemotherapy, you could try sentinel node biopsy, and the same principle applies. After sentinel node biopsy, if it is positive, can we just give radiation to the axilla, or can we give? So again, there is a set of trials which we will be looking at, and the logical conclusion to this step is, next is, can we avoid doing the sentinel node biopsy totally at all? And there is again a whole set of trials which are addressing this question. So we first come to this group when we have clinically node negative, but the sentinel node is positive. You have done the sentinel node and it is positive for the axilla. So you have a PN1 axilla, and the biggest study, the most famous of these studies is the Z11 study, which actually was brave enough to ask this question, that can we not treat the axilla at all? Of course, they did a very select subgroup. They used a very favorable subgroup, strong ER positive, early tumors, less than 3 centimeters, and all of them had breast conservation and all had radiation to the axilla, radiation to the breast. The axilla was not included as a separate field in the Z11 study, though we don't have very good quality check on the radiation in that field. The last two in this column, the AATRM and the IBCSG, looked at avoiding axillary treatment for the micrometastasis in the sentinel node. So only for micrometastasis, it was found that it is okay not to treat the axilla any further. And the Amaros and the Otazor are the two studies which looked at doing radiotherapy to the axilla instead of axillary lymph node dissection for a sentinel lymph node positive. And mind you, all these studies, if you look at, they have a fairly good follow-up of 9 to 10 years, and they have all shown that there is no downside to not treating the axilla, whether you do it with radiotherapy or even without radiotherapy in select subgroups. So if you look at the first three, that is the IBCSG, the AITRM and the ACOSOL, they used only observation. They did not give nodal radiation as a separate entity, though there was some controversy in the Z11 study when some people use high tangents, so some part of the axilla did get irradiated. Whereas the Amaros and the Otazor used radiation instead of surgery for the axilla. So you have nodal irradiation which seem to give you equivalent result to surgery. So the question was, if you have a sentinel node positive, do you really need to treat the axilla with surgery again? And that is what they seem to be addressing. Now there are three more studies, the POSNOC, the Senomac and the Synodar one, which are also addressing the same issues. They have not yet, the detailed reports have not been published, though the 3-year results are available now and it is showing non-inferior for these two, Senomac and the Synodar one. But most of these studies, what you must remember is, the Z11 study and now took very select subgroups, very favorable subgroups, So some of the attempt was to try to include other subgroups also in this study, and this is what, see, the Posnock, the Synodar and the Acosop Z11 did not have nodal irradiation, whereas Sinomac, Amaros and Otosor had nodal irradiation. So when we look at the long-term results of these studies, where after 15 years, 20 years, we can be able to reach a conclusion whether nodal radiation does add to the survival or does it have a really effect on the overall survival. And then they have tried to include other type of patients who are not included in the previous trial. So older patients who had micromets in addition to the positive macromets, and patients who had non-luminal and HER2 positive patients, and even male patients were included in the Sinovac study. So they are trying to make it more inclusive and see that in all patients, irrespective of this thing, if they are clinically node negative and sentinel node positive on this thing, can we just avoid treating the axilla either with no surgery or give radiation? These are both options, and both of them seem to work right now at present. Now, Posnock is still not published the results, but it has included multifocal tumors, it has included mastectomy, non-luminal and microscopic extrascapular spread has been included. So, the next logical conclusion is, can we omit the sentinel node altogether? That means we don't need to do sentinel node at all. So, now there are some scenarios where we definitely don't do sentinel node now. We just accept it. When you are doing it for a breast conservation for a ductal carcinoma in situ, it's not mandatory to do a sentinel node. When you're doing a prophylactic mastectomy for a BRCA mutation patient contralateral site, you don't need to do a sentinel node. And the elderly patients, also there have been studies which have shown that you can get away without treating the axilla with a sentinel node without addressing the axilla surgically. So, but the direction in which clinical trials are now moving, we are looking at a number of trials which are addressing that can we avoid the sentinel node altogether, can any surgery in the axilla in those which are radiologically and clinically negative axilla. Now, the CN0 patients with which the trials which are looking at this, the sound, the INSEMA, the BOOP, the SWAPET and the Nautilus trials, these are all studies which are looking at early breast cancer. When you do breast conservation, clinically node negative, can you just not address the axilla with sentinel node at all? And whereas even now the trends are changing, that means in the high risk node negative, triple negative or HER2 positive, slightly larger tumors, people are going for neoadjuvant chemotherapy. So in that group also, can we avoid doing the sentinel node is a question which is being addressed in two trials, the ASICS and the UBreast trial. So some of the studies which looked at this thing, out of this only the first trial, that is the sound, has been published. Others are all still yet to be published, this thing. So the sound which is just recently published has really shown and taken a very select group, T1 tumors less than 2 centimeters and breast conservation and all receiving whole breast irradiation. In that group they have looked at sentinel lymph node is now the standard arm, and the control arm, and the control arm and the treatment arm is the observation only. And they have shown that with the 5-year follow-up, they have shown that it is not inferior. That means even if you don't address the axilla surgically, as long as you're doing, but mind you, this group is very specific, it's T1 only, and for breast conservation with whole breast irradiation. So you're not radiating the axilla separately. Now, the other three trials, the INSEMA, the BOOK and the SWAPET, have tried to expand the criteria a little more. They have taken T1 and T2 tumors. That means they have taken up to 5 centimeters, and they are still looking at whether you can still get away in the nose. Clinically N0, you can get away with without addressing the axilla. In the SWAPET, the Chinese study, actually they are looking at a special investigation, that is the lymph PET, where you have a separate machine which is dedicated to looking PET scan of the axilla alone, and if it is PET negative, then you don't do surgery for the axilla. The Korea trial is almost the replica of the sound trial, which is, these are all yet to be published. So right now the sound is only published trial, and definitely it shows that yes, you may not need surgery for the axilla in a select subgroup. So what about the N1 patient? Now these are all for the clinically node negative, ultrasound radiologically node negative patient. But in the N1 also, people are looking at giving neoadjuvant chemo, converting it to an N0 group, and then doing a sentinel node biopsy. And that has become fairly standard nowadays, becoming more and more the routine now. The initial trials, the Alliance, the Sentina, the SNFNC, basically they were trying to look at establishing the reliability and the false negativity rates to ascertain whether we can reliably do a sentinel node post chemotherapy in this group. So these trials have addressed that issue and have actually confirmed that yes, you can. They did mention some criteria that you have to use a dual technique for detection of the sentinel node, and you have to remove at least 3 sentinel lymph nodes for it to be called adequate. And you have targeted axillary dissection also in this group, where you initially target the nodes. You can use either radioactive seeds or you can use magnetic beads, and then after chemotherapy you remove the targeted nodes plus the sentinel node. And the Alliance 202 and the NRC B51 have looked at replacing the sentinel node positive. If the sentinel node is positive, give only radiotherapy to the axilla, and again not completing the axillary dissection. So, in the people in N0 group who are high risk N0 who are receiving neoadjuvant chemotherapy, can we also avoid axillary surgery in those? And 2 trials are looking at that. One is the U-breast study, basically looking at T1 to T3 N0 group, which are triple negative or HER2 positive who receive neoadjuvant chemotherapy. You do breast conserving surgery. If there is a pathological CR, the primary side, then you don't address the axilla at all. So this is something which is now being tried, which is going on, and the endpoint being a 3-year axillary recurrence-free survival. And the same sort of study is the ASICS trial, which is looking at omitting the SLNB after neoadjuvant chemotherapy in the high risk, that is triple negative and HER2 positive. But here they are using MRI after the as a radiological CR. If there is radiological CR, then they don't do a axillary surgery at all. So again, we are awaiting the results of these trials to know whether we can avoid axilla even in the high risk group. Is this thing. So just in this thing, when we started with axillary dissection for all, we had moved to sentinel node biopsy and doing axillary lymph node dissection if sentinel node is positive. But then we have looked at 2 alternatives. We have some studies which looked at only sentinel node biopsy, no RT at all, like the Z11 study, and some which looked at RT for ALND, like the Amaros and the Amaros study. And now we are looking at, based on the sound trial, can we omit the sentinel node totally? And there are a few other studies which are yet to be published, but yes, that's where the direction is moving. Similarly, in the CN1 and the high risk CN0, where you are using neoadjuvant chemotherapy, again you can do neoadjuvant chemotherapy followed by SLNB. The initial studies address the accuracy, the false negativity rates, and now regional nodal irradiation instead of axillary lymph node dissection is accepted as a treatment of choice, along with targeted axillary dissection if possible. And whether we can omit sentinel lymph node biopsy in this group is still something which is being explored, but not yet the norm. But there are some situations where we still base our decisions on the axillary nodal status. So we still need to know the axillary nodal status, and that means our surgical therapy information will be needed to assess the axillary our treatment rate. Some of which is whether you are going to use. Some people believe in regional nodal irradiation very strongly, and they give it for N280, that means more than 3 nodes positive, you must give nodal irradiation. So for that you must need to know the number of nodes. Then in luminal B, whether you should add chemotherapy to endocrine treatment, many people base that decision on the nodal status. Then whether you should give 5 years, 7 years, 8 years or 10 years of endocrine therapy, again could be based on nodal status, so you need to know the nodal status for that. Then some people use this information of nodal status to decide whether to continue dual anti-HER2 therapy or not. And the monarchy data has shown us that abemaciclib can be used in the post-neoadjuvant setting for those who are node positive, based again on number of nodes. And similarly, the germline BRCA mutations, whether to use olaparib for the node positive group. So these are some indications where we use the nodal information to decide our adjuvant treatment. Where the nodal information is not going to alter your adjuvant treatment, then maybe you could avoid axillary surgery altogether. So in conclusion, I will just say that axillary surgery contributes to local control, yes, but it does not impact the overall survival in breast cancer. This is something which we have got from the long-term results of the NSABP04, the Milan study. We have 25 and 30-year follow-up data now, and we know that the overall survival is not going to be any different just because you remove the nodes or not. Then axillary lymph node dissection we know now is not necessary for local control in early breast cancer with limited nodal involvement. That means the early N1, not a very bulky nodal disease. And we must keep in mind that more and more early cases are being detected. It's just a matter of fact that we are seeing more early cases nowadays. So it is really relevant that whether we can avoid axillary dissection totally, because it does have some morbidity. And we have recent trials have shown that in both clinically node negative and node positive patients, sentinel lymph node biopsy after neoadjuvant chemotherapy just does decrease the need for axillary lymph node dissection, and without any apparent increase in the regional recurrence, despite some studies showing a slightly higher false negativity rates. So, and total avoidance of axillary surgery is definitely possible in certain subgroups like the sound trial has shown us. So this is something which we are moving towards, the de-escalation of the axilla, that we may not need axillary at all and use only imaging data to be able to make our decisions on adjuvant treatment besides the molecular data. Thank you.
Very crisp and clear presentation. Now the audience can ask you questions for clarification. Basically, the number of surgeons are less, so you can interact more with more questions.
Sir, in the sound trial, they have only the ultrasound evaluation.
Yes.
So in the follow, have they done ultrasound evaluation or was it just clinical examination?
No, just clinical evaluation. I think they have used the annual mammograms.
Yeah,
That's No, there is no higher incidence of axillary recurrence or in the 5-year follow-up data.
So only the baseline ultrasound, and they avoid the axilla, and then the clinical examination only.
Yes, clear. But full breast radiation is given.
Right.
Breast radiation is given. So the lower axilla does get some radiation to that.
Then the second thing is, can you just elaborate on that total targeted axillary dissection after that neoadjuvant? What does it mean?
See, basically before surgery, that means before you start the patient neoadjuvant, one ultrasonically you can localize those nodes. You can inject radioactive iodine or a magnetic bead you can put into those nodes. And after you give neoadjuvant chemotherapy, you do the sentinel node. The sentinel node may not be the same node, it may be some other node. So you remove the sentinel node and you remove the targeted nodes with either wire localization or with using the gamma probe. So depending on what method you use to localize the node, some people have even suggested charcoal, injecting of charcoal into the lymph node, but that's not very popular.
Ideally must be used in clips, right?
Yeah, you could use clips also, but when you use clips, you have to use a wire for localization of those nodes afterwards.
So removal of that node.
Removal of that node also. That node may not always be the sentinel node. It may sometimes be the sentinel node. Sentinel node and the targeted node may be the same in a number of cases, but in many cases we find that the sentinel node is not the same as the targeted node. So you may find a different sentinel node, and you also remove the targeted node in addition. So this is targeted axillary dissection.
Right.
Can I ask? So, what are your thoughts on the internal mammary?
Right now, there was a time when I used to do internal mammary node, sentinel node sampling, because when you inject the routine sentinel node technique, you find that you will not get, you will get only axillary node, but you have to do a deep injection, you can get sentinel internal mammary node. And we have actually started, and I have found one case where I found the internal mammary was positive and axillary was negative. Axillary was negative. That can happen rarely. But as of today, no study has shown that surgical removal or surgical treatment of the internal mammary has in any way influenced survival. Whereas if the sentinel node, internal mammary node is positive on any imaging technique, you definitely would advocate radiation for the internal mammary node.
And which affects survival?
It changes the stage. The internal mammary node is positive, changes stage, so automatically affects survival, yes.
So anything in the horizon which is going to come?
Not that I am aware of.
And very interesting talk. Just one simple question. As radiation oncologists, we look at the axilla from the levels, level 1, level 2, and level 3.
Yeah.
And when the axilla is properly dissected, sometimes we avoid the axilla and take the level 1, level 2, and the level 3 stations. So, in the light of your talk, is there any segregation, or when you say avoiding axillary radiation, does it mean avoiding the whole axilla, or does it include a supraclavicular field radiation in this situation?
No, if it's a node positive, supraclavicular will get included automatically. You avoid the axilla anyway. But regional nodal irradiation, when I say, I mean including the axilla separately, despite axillary dissection. Some people use regional nodal. 2 studies, a French study and one more study, have shown a benefit, survival benefit with regional nodal irradiation. That means you irradiate the axilla in addition to irradiating the supraclavicular, and the internal mammary is needed.
You look at the biomarkers specifically to take a decision, for example, to negative or any other to.
You could, yes.
Because
definitely the high risk groups have a slightly higher risk. But I don't think India has really looked at it in that sense as specifically for the molecular subtypes or a different higher risk group. But generally, there are some groups which definitely believe in regional nodal irradiation having a survival benefit at a slightly higher toxicity. You do get, it's at the cost of a little more toxicity, but you supposedly get the survival advantage, especially the French study showed that. But not everybody accepts that. Whether it's really worth, once you've done a proper axillary dissection, do you need to increase your risk of lymphedema by adding radiation to the axilla? This is a question which is...
There's no lymphedema these days. We don't see it because...
Yeah, because everything has improved. The quality of surgery, quality of radiation, both have improved a lot.
Yeah, so it's in...
But you do still see, no, don't say you don't see, you do still see occasionally.
With the sentinel node dissection matters.
Yes, even with sentinel node you can get lymphedema. But it's very rare, yes, but you can get, yes.
Thank you, thank you.
Can we avoid lymph node dissection when you said neoadjuvant chemotherapy and the primary tumor has completely responded?
That is what the ASICS and this thing is doing. 2 studies. We don't have the results as yet. The 2 studies, the breast and the ASICS.